All right, so it's my pleasure to introduce our next speaker for the last part of our session today. Eleni Tigas is the Chief Medical Officer for the Preeclampsia Foundation, the North American Patient Advocacy Organization for Hypertensive Disorders of Pregnancy. She leads the organization in championing patient and provider education in clinical and outpatient practices, catalyzing science, and building partnerships to improve pregnancy outcomes and hypertensive diseases of pregnancy. She's also been involved with the Council for Executive Council for Mama's Voices, a supporting partner for the AIM program, and a previous voting member of the Council for Patient Safety in Women's Healthcare. She also serves as a subject matter expert for the World Health Organization, the PRECISE and PREEMPT technical advisory groups, the Hypertension in Pregnancy, and the Pregnancy and Heart Disease Task Force for ACOG, as well as several state perinatal quality collaboratives and their task force related to preeclampsia and hypertension. She is the principal investigator on the preeclampsia registry, and probably most importantly is she has personal experience having survived preeclampsia twice, although her first born daughter did not. So welcome, Eleni.
Thank you so much. If we could pull the slides up. Thank you, and we can go to the next slide. Thanks so much for including me. Hopefully most of you all caught yesterday's presentations, because I'm going to be referencing some of what you heard yesterday. And I also recognize that I'm pretty much the only thing between you and Friday afternoon happy hours. So I'm going to fly through a lot of my material pretty quickly. I guess my call to action would be that I am going to be sharing quite a few tools with you that relate to a lot of what you just heard in how to deploy some new practices in the ED setting or an L&D to recognize the very real presence of postpartum preeclampsia. So the women that you see here on your screen, Vuann, Rebecca, and Kelly, all had severe postpartum preeclampsia stories. And their stories very much reinforce the themes that you heard yesterday in a lot of our patient presentations from our patient family partners. They also introduce a few new themes. Rebecca is a fit runner who was advised to monitor her blood pressure postpartum. She was given instructions about symptoms to look out for. She had an appointment with a home visiting nurse a week after delivery. Kelly is an OB nurse herself, and so she presented to the ED postpartum and saw firsthand how her severe range blood pressure was not adequately treated, how the ED staff was not familiar with postpartum preeclampsia, how the ED pharmacist did not know the correct dosing for magnesium sulfate, really how the ED staff were out of their depth, and it took way too much time to finally get her readmitted to the OB unit. Vuann had multiple complications during pregnancy and during her delivery that she expressed concern about, but she was dismissed and discharged after delivery. 2 days later, she sought medical care and was dismissed. 2 days after that, she ended up in the ER, where she was transported eventually to a facility that could address her critical needs. She had gained 33 pounds of extra fluid affecting her heart function, developed pulmonary edema, and severe range hypertension. So all of these and many of the other stories that you heard yesterday really beg what I call the very important questions that your units and healthcare systems may want to consider. What is the value of moms monitoring their own blood pressure at home after discharge? Where do we tell moms and their partners to call or to go after delivery if there are concerns? What should we explain to them? How do we prepare the emergency departments, as you guys have been talking about? How should they identify and then triage postpartum moms? How do we prepare moms and their support partners, I keep emphasizing that, to know what they need to know and how to effectively advocate for themselves? What needs to be done at discharge? And what can be done afterwards, and what can be done throughout their prenatal, during all their prenatal visits. Next slide. So for the next few slides, I'm going to quickly introduce 4 areas and some tools that can help you address some of these considerations that I'm throwing out for you. Next slide. First one we're going to talk about is signs and symptoms, which was actually being discussed a little bit in the chat. The clinical characteristics of postpartum preeclampsia are the same as regular, if you want to call it that, preeclampsia, and the same maternal organs are affected, so the same symptoms matter. When these symptoms are being reviewed with mom, again, during the prenatal period, but also at discharge and any interaction with healthcare providers in the postpartum period, they really should be emphasized that they can still matter up to 6 weeks after delivery. Tools like this refrigerator magnet can happen. You see the list of symptoms on the left side of your screen. I think one of the things that I want to note about this is we love to present these symptoms in these nice, clean, sort of clinically pure ways. But the reality is that we as patients exhibit them, experience them, and describe them often very different than you see on this list. So I'll give the example of epigastric pain or upper right quadrant pain. That isn't always very neatly and conveniently located right over the place of the liver. A lot of times it refers to our neck or to our shoulders or to our back. And so what we report as other kinds of pain really is emanating from epigastric pain or upper right quadrant pain. So I think the message there is just to be a little flexible in your understanding of not only how signs and symptoms of preeclampsia are conveyed and educated and informed to the patient, but then how it might be reflected back. Next slide. A lot of the tools that we provide, like the tear pads, the explainer videos, including one that we have specifically on postpartum preeclampsia, which can be played on like internal hospital education systems in waiting rooms, etc. And the postpartum tear pad, we're showing it here in Spanish just to illustrate that all these materials are available in English and Spanish. And a rubber bracelet or a wristband, which I'm going to show you a picture of in a few slides, but it's been referenced a little bit in the chat, which really emphasizes that moms are still at risk after discharge. By wearing this wristband, they're able to recognize that every time they present to ED or every time they present to L&D to remind them that they are still at risk. Any hospital that's on this call that's part of the Texas AIM Hypertension Bundle Collaborative will have received a sample kit of all these materials that I'm talking about. And they're all available, and there's information on your screen about how you can order more of these materials. Next slide. A1 also offers a post-birth warning signs handout, and the CDC has adopted the urgent maternal warning signs that were developed by the Council on Patient Safety and Women's Healthcare and that are part of the Hear Her campaign, which we'll talk a little bit more about in a bit. Next slide. As important as these printed and digital patient education materials are, how you communicate is probably even more critical. You heard a whole seminar on patient-provider communications yesterday. So to a great extent, this list that I'm showing you here is redundant to what you've already heard. But I do want to reinforce the importance of chunk and check, which was talked about a lot yesterday, and teach back to confirm understanding of the material with open-ended questions. So how that relates to teaching around signs and symptoms might look like reviewing signs and symptoms and then turning to the patient and saying, what might cause you, what might you experience or feel that would cause you to come in to the ED or the ER or to call, whatever the action is that you want them to take, and ask them to teach it back to you, which gives you not only an opportunity to clarify and confirm what you've taught them if it's a little bit off, but reinforces the message in their own mind. It's important to recognize that in this whole area of patient communications, not only are these strategies like chunk and check and teach back important, but messages, this is sort of communication 101. Messages must be repeated to be remembered. It's important that we have consistency in the messages and that they are presented in a multitude of mediums because we are all different kinds of learners. So present it visually, present it by speaking, presented in video, presented in printed material, but make sure the messages are consistent and that they're repeated often. I think it's also important to recognize that there may be cultural differences in how some of these symptoms and materials are understood. So we hear blood pressure as an example, sometimes referred to as my pressures, or in the case of diabetes, referred to as my sugars. And there might be very different terms, and particularly in some of the areas in Texas where Spanish might be a primary language. You know, what are some of the typical terms that are used to refer to these symptoms that we should be alert to? I cannot emphasize enough, as I've already mentioned, the importance of bringing support partners into any education process. Oftentimes, they are better equipped to recognize when something is off with mom. So I do want to emphasize that. Next slide. So the big question is, when should a lot of this be done? And the focus typically has been, and there's an opportunity to focus on this as an implementation at discharge and developing some discharge protocols around some of this. Next slide. This is not intended to be a hypertension bundle explanation, but rather to say that in the hypertension bundle, there are a number of actions that are being prescribed that would ease the move into recognizing postpartum preeclampsia. So a couple of things like requiring a follow-up blood pressure check and actually having it scheduled at discharge. Checking for barriers to keep that appointment, or sending her home with a blood pressure cuff, particularly with the augmented use of telehealth. Sending her home with symptoms information and reminders, checking for her understanding using TeachBack, and sending her home with a clinical summary of what happened to her in that pregnancy and in that delivery in terms that she can understand. And I'm going to show you a template that you can use for that clinical summary. Next slide. One of the things that we've done, and I fully recognize that this is not the nifty little infographic that everybody would like to have, but it is a 2-page synthesis of everything that we as patients should experience if hypertension protocols are being followed correctly in the hospital. This is what we would experience. So we're not going to know whether or not the pharmacy was stocked with magnesium sulfate and the correct antihypertensives, but we are going to know, and our support system is going to know if our high blood pressure was treated quickly. And that certainly is one of the many things that is stipulated in the hypertension bundle. So this patient bill of rights is something that's available. And I just want to point out that if you've got your smartphone nearby, I do use QR codes throughout this presentation. Aim it at your screen where it says scan me, and it'll take you right to our website where we have this patient bill of rights. That is a way, it's a handout that you can send, that you can hand to patients, that's written through consumer language and helps them understand, this is the practices that I should have expected in my hospital experience with hypertension and pregnancy. Next slide. Here's another opportunity, another tool, if you will. We've deployed the cuff kit now. Over 10,000 of them have gone out across the country, and they include what you see on your screen here. Most notably is not just that there is a validated in pregnancy blood pressure monitor, but that there are educational tools that have been developed specifically for home blood pressure monitoring. And you'll see, if you can see the wristbands that we referenced there, they're part of the kit. And they say still at risk. And they not only provide a URL for families to go to get more information about postpartum preeclampsia, but they do serve as that visual reminder, both to healthcare providers and to the family themselves, that I am still at risk for several weeks after I've had my baby. So those wristbands are not only available as part of this cuff kit, but they're also available on our marketplace, which I showed the URL for earlier, and I'll type it into the chat a little bit later. Next slide. Kind of along the same lines of equipping patients with news and tools that they can use, we know that, and this isn't necessarily the point of today's conversation, but I hope everybody knows that there is unequivocal evidence that those of us who had preeclampsia are at significantly higher risk for long-term cardiovascular disease. That means our heart health and our entire cardiovascular system is at risk for the rest of our lives. There is very little information that's ever provided to us about this. Most of our primary care providers don't even know this. we've developed a tool in combination with the International Society for the Study of Hypertension and Pregnancy called Beyond Pregnancy. And it's a tool to help us as consumers work with our providers to track some of those things, like what was our pregnancy history? What are some of the comorbidities? How can we track our blood pressure, our BMI? What's important in some of our serum labs? And what are some ways, some tangible ways that we can lower our CVD risk? So again, there's a QR code here where you can go and grab this tool, and we just encourage you to encourage your patients to sort of take some ownership and some engagement in their health. And these are tools that can help with that. Next slide. I mentioned earlier the clinical summary, this patient clinical summary after a severe maternal event. It is a one-page document that I do realize will put a little bit of onus on the healthcare staff to translate information from her EMR or from records onto this one-page document, but it will pay off in numerous ways for the patient. Number one, it tells her exactly what happened. I can't tell you the number of patients who don't fully understand their preeclampsia HELP syndrome eclampsia episode and often misrepresent it as something else. By putting this information very cleanly and simply on this one-page form, you are equipping her to understand what happened to her, which actually succeeds in helping her mental health recovery. A lot of our mental health baggage, if you will, from our severe maternal events is because we don't fully understand it. So this helps with that. It also helps because, unfortunately, all of our EMRs and all of our health information does not travel around the world with us. So this is a way that we can help transition of care and transition of information to other healthcare providers. And it really is ultimately a self-empowerment type of tool. So next area, how can you empower your patient voices to be heard? I want to just give you a couple of ideas for that. Next slide. One of them is literally putting a sign up around your EDs that says, are you pregnant or have you been pregnant in the last 6 weeks? Tell us. And we've heard some references to that in some of the material that we've covered already. Next slide. The other tips that I would offer include teaching patients to use their brain and teaching patients how to cuss. So those acronyms, BRAIN is benefits, risks, alternatives, intuition, and nothing. I've seen BRA before, but I've not often seen intuition and nothing. But this is something that can really inform patients throughout their pregnancy and really lifelong how to engage in the healthcare system and how to stop and ask effective questions like, what are the benefits of this treatment recommendation, what have you? What are the risks? What are my alternatives? What is my gut is telling me about this? And what if I do nothing? The other thing, and I know that nursing staff is often advised to learn how to cuss so that their voice can be heard in what may be a patriarchal environment, but let's teach patients how to cuss. I'm concerned about this. I'm uncomfortable. I don't feel safe. These are trigger words that healthcare providers are often trained to pay attention to. So if we can teach our patients to use these same words, they will capture the attention when needed. A more extreme tip might be asking for your medical records to enter into your medical records the concern that you've stated if you feel like you're being dismissed or brushed off. And as I mentioned earlier, sending her home with an accurate clinical understanding of what happened. So these are just some tools that we recommend. And one thing that I'll say, and this has actually been found in studies over and over again, when you're teaching patients about symptoms, one of the unintended consequences is that you yourself as a healthcare provider also learn the symptoms because you may not have been as familiar with them. And so the act of teaching teaches you. I think that's a very famous acronym, right? If you want to learn something, teach someone else. Anyway, next slide is talking about some ways that we can infuse healthcare providers with this notion of listening to patients. One of the recurring themes, next slide. One of the recurring themes in yesterday's patient family partner stories was this idea of not being heard or listened to. The CDC has launched an entire campaign called Hear Her, next slide, that includes a number of social media assets, posters that you can post in your staff break rooms or even in public areas. But all of them are really intended to remind you to truly listen, that it is your most important tool. Now, I will say, I was actually kind of amused. If you go to the next slide, one of the patient family partners yesterday told a story about how important it was for her to get her baby checked out of the NICU as soon as possible. And she really emphasized that as something super important to her. I chuckled because I remember feeling the exact opposite. When my baby was getting ready to be released from the NICU, I was scared to death and didn't want him coming home because I didn't have the first clue about how I was going to take care of this preemie. My point being that not to discount the lessons and the stories that you've heard, because they're all extremely instructive. Learn from the stories, but most especially learn that your number one job is to truly listen, to ask questions for clarification, to seek first to understand that patient's story, because her story may look very different than another patient's story. And from that position, from that foundation of understanding her environment, her culture, her story, her proclivities, that's going to help you educate her, inform her, advise her, guide her in a way that's much more accepting to her. So don't assume all stories are alike, but do assume that all stories are going to be instructive to you. So next slide. So just in quick summary then, education, discharge protocols, helping patients to find their own voice. Honestly, all these together as a constellation of interventions will lead to improved postpartum patient outcomes. I will leave it at that because, as I said, I know we are only between here and a short little bit here before we hit into our weekend. I always like to leave with this last question, because we always bombard each other with with so much information in these training webinars, and we get all enthusiastic, but then the next day we go back to work and it all goes right out the window. So always leave every session going, what's one thing that I'm going to do starting tomorrow? And if we could take 15 seconds to pause and think about that before we go back to our panel.
Perfect. And everybody's doing that. I did put the marketplace in the chat box for you, Lenny.
Thank you.
Great stuff. And really, thank you for everything you do for the Preeclampsia Foundation. Really, I like the way you framed it into those 5 different categories, ways we can think about it. A lot of the things you mentioned were coming up in the chat box about the wristbands and the signs to have patients advocate that they're pregnant or were recently pregnant, and the ED that'll help kind of take the burden off the ED folks. All right, so if I can have our other speakers come back online. We have about 7 minutes left in our session. And I think one question that came up related to your talk, Lenny, was the preeclampsia tool you guys have developed from the Preeclampsia Foundation is awesome. And there was some comments in the chat box about, have you worked with any of the EMR groups to see if it could be integrated into Epic? Somebody in the chat box said they have something similar for Cerner. I'm just wondering where things are at with that.
Absolutely, and I just threw into chat that we do offer digital licenses, and we have worked with hospital systems that have integrated right into their EMRs, so that is an option.
Perfect, great. I think Dr. Davidson, you had a question?
Yes, thank you. I thought it'd be easier to just ask it than type it in the chat. And my question is actually for the ED providers. And again, thank you all so much for joining us. I feel like over the last couple of years, I've had to relearn how we educate patients about preeclampsia and postpartum. And I've had to shift my counseling from being, delivery is the cure to it won't get better until you deliver, and it can get worse first, but you are still at risk for getting this after delivery. So just in kind of thinking about how to approach this project around the education, because I was even talking with a surgery resident who's in his 3rd year of residency, and as I was going through preeclampsia, he was like, wait, that's all different than what I learned in medical school, and that was just 3 years ago. And I was like, yeah, we've had about 2 different practice bulletins published since you finished medical school. And so what is the current education for emergency medicine residents and even for the faculty who've been doing it or the providers who have been out of training for a long time, what do we need to do to kind of readdress that whole, when you walk in, like what would trigger someone to think, okay, the blood pressure is high, even if we don't have a system for screening about recently postpartum, what would make someone wonder, could this be postpartum preeclampsia that I need to treat right now? Or do we have kind of still in our head in the emergency department, once you've delivered, it's gone, and that's not what we're dealing with anymore?
I mean, I can't speak for all the emergency departments across the country or all the training programs, but you know, we have a pretty good relationship with our OB. So Sean Blackwell is our chair. He and I communicate probably twice weekly about different stuff, and his group and our group are engaged with each other and providing each other's groups education on different things. You know, we've collaborated together on, for instance, maternal hemorrhage. We just had a drill in our emergency department on maternal hemorrhage. We have one coming up actually on hypertension. So it's going to be a drill on an eclamptic patient. And so I would like to think that at least locally, you know, the education that we're providing is consistent with the standard that obstetric experts expect for their postpartum patients. And so, but like I said, I can't speak for everybody, but that's just sort of how we've approached our educational efforts, is to sort of collaborate with our institutional experts to make sure that we're together providing you know, the most up-to-date information.
That's a great question, Christine. I'm glad you asked that, because I know at the Maternal Morbidity and Mortality Committee that has come up, not necessarily for the ED, but for psychiatry training programs. Is there any requirement for a rotation in women's health related mental health issues? And the same for ER medicine. Are there required training modules or needs related to pregnant and postpartum patients presenting to the ED? So that may be an opportunity that can be brought up through the M&M committee. I think we may have brought that up before in some of our discussions, but not necessarily for the hypertension side. So I think an opportunity for sure. Another question that came up in the chat box was, so whether we screen for pregnancy or recent pregnant status in the ED or not, do your EDs have a specific policy or protocol how to manage those patients when they come in as far as treatment of pressures or like an SDO or something like that? Dan, do you want to start?
Yeah, I'm happy to answer that. So we do. So we've, together with our obstetric colleagues, we created sort of like an order set or a power plan when a patient comes in with preeclampsia or pregnancy-induced hypertension. It has a number of labs pre-checked that the patients are going to need. It also has all the available medications that the patient would need urgently right there, ready to click, so that nobody has to search, right, or look up, you know, a medical reference for what am I using for preeclampsia, right? The medications are right there. It's hydralazine, right? It's labetalol. You know, magnesium's already there. They don't have to look up the dose in a medical reference. It's already a 4-gram dose, right? There's a bolus dose, and then there's a second magnesium infusion rate as well. So they're going to click both the magnesium doses. So I think things like that, sort of having order sets and power plans, using your electronic health record to sort of leverage some of those things so that it's not based on any individual's sort of recollection or whether or not they have a cognitive deficit in a particular area, right? Using your EHR to help standardize how we're delivering care.
Good. Thank you very much. There's a lot of discussion about empowering patients in the chat box as well. There was a really good suggestion about engaging health plans in this project because they have processes in place to educate patients in the second, third trimester. I think that's a great opportunity to work with some of the state health plans to do that. There was a question in the chat box about do any of you all have hard stop documentation in your EMR related to checking the pregnancy status at all? I suspect based on our conversation earlier, probably not. But
Yeah, it's not a hard stop for us right now, but it's certainly something to think about. And actually, as we're just like, I'm hearing it, hearing all the different speakers talk, I'm sure everyone, at least folks who have a cerner for their EHR, at least in the emergency department, we have all our patients listed on the tracking shell, and you can see all their vital signs. And if their vital signs are over a particular level or under a particular level, they highlight as abnormal or critical, right? And so could we leverage our EHR so that if a patient did recently deliver, right, that their vital sign like cutoff for what's abnormal for a blood pressure is should be different, right, for a 24-year-old who's 5 weeks postpartum than, for example, a 65-year-old, right? And so how do we leverage the EHR to make our EHR smarter to help those of us in the emergency department who are just constantly interrupted in their constant distractions?
Well, thank you very much, everybody. I want to thank all of our speakers for this session this afternoon for their insights and expertise. I learned a lot, so thank you all for being here. I also want to give an incredible shout out to the TCHMB staff who are behind the scenes managing everything today and throughout this meeting and prepping for this meeting. It's been a huge task. Just a reminder for there'll be an email coming out to register for your CME credits. I'll be watching for that. The survey to be filled out, then you'll get your CME credits and your certificate to follow. I put in the chat box if you want to be an influencer, please like us on Facebook and Twitter. I'm probably getting annoying with that. And advanced slide. And just a reminder, save the date for next year's in-person TCHMB Summit at the AT&T Center in Austin, February 15th through 17th, 2023. And with that, I will end our session today, and this is the end of the summit. So thank you all for being here, and we look forward to seeing you next year.